Thank you very much. All right, we're back into Talk 2. Welcome back from the break, everyone. So what we're going to continue on today is starting to look a little bit about inputs and processes of health services. Now, I've had to combine a lot of these together into one talk. So, we are just scratching the surface, but hopefully it is an introduction and to give you a little bit of a food for thought for later. So each of these is 1 week's worth of talks and seminars. So today we are going to cover formal and lay care, diseases and medical knowledge, a bit about healthcare professionals and users of healthcare. So you can see that it's going to be tight on time. But with healthcare professionals and users of healthcare, we're going to come back to a seminar tomorrow, and I have a bit of reading, which I will give to you at the end of the session, so you can go home, bedtime, reading, and have a little bit more of a think if you're interested. And then we'll come together tomorrow and have a bit of a seminar time to go deeper. So not to worry if you think, oh my God, what was that all about? It just went through so quickly. Not to worry. Okay, so inputs and processes of health services. Now, while one of the models, now we say models because it's conceptual, and it is reductionist, as all models are, to help us just to have a framework of thinking about things. And we found that in this course, the Donaldian model is really helpful to think about all the formal activities of healthcare in a way of processes, of inputs. Let's start from the beginning. Inputs, processes, and outcomes. And so what do we mean by inputs? So it is actually quite conceptually easiest to think about all the things that goes into the health services. So it could be the structure, the resources, the professions, the beds, the centers, the facilities, things that we are putting in to the health services. Then we have processes, activities. We were chatting before the start, looking at, how do we measure and evaluate good quality EMS services? Is it with processes? Is it the times it takes to get people from one place to another? Is it the outcomes? Is it survival? Processes is the activities that health services does. So it could be, how many patients do we immunize? How many operations do we do? How many sessions do we give to patients after their surgery to get them walking again, physiotherapy-wise? All these, we are assuming that doing them are good. We don't know for definite, but we know that we do them, and we measure how much we do them, and that would be a process match. And then there is also outcomes. This is what we're all about, isn't it? Actually, everything else doesn't really matter if the outcomes aren't good. We're trying to get people to less deaths, get better, what their symptoms are, the disability, and the quality of life. But we also will increasingly know that actually we don't necessarily know these outcomes. They're very hard to measure. And perhaps that is why we resort to measuring the first two a lot. We don't know if patients are what the quality of life is, what the symptoms is. But so then we say, oh, you've had the operation. That's good. You've had it. You've had your gallbladder out. It must be good. So that those are the dynamics. But it's very helpful to think about healthcare in these kind of dimensions. The outputs, just to point out that a lot of people use outputs. It's a very economic-based term, and people talk about outputs, and outputs are a combination of processes and outcomes, mainly because the latter is so hard to define. We need to use a kind of parameter to measure how effective things are, and so people lump outputs together, and actually it's a combination usually of processes and outcomes, just to be mindful of that. Health services are also organized in different ways, as we might all know. Some of us talked about we're general practitioners, so we worked in general practice. Where would that come in? Primary care. So starting from primary care, we know we're outside of hospital. Usually the first contact of the patient has community pharmacy. used to be low technologies, and the doctor in the health facility seeing the patient, 10-minute consultation. You know, the most you could do is a blood pressure if you're lucky. If not, it's the stethoscope on the chest. You know, low technology, but it is changing in many countries. We now, probably Japan as well, mobile imaging units, MRI scanner in a truck. So, you know, that is changing. You can have screening services mobile now. Usually, in the past at least, there's been continuity in the family. You know, you've got the traditional family doctor in Canada. It's still called the family doctor. But you see the same person, the whole generations, the entire family see that one doctor. It should be the parish doctor. You know, one town in England has one doctor and the priest, and everyone used to know he is the doctor. That's the doctor's house. It probably is the same in Japan, isn't it? I've visited some similar houses, and there's the Lord's house and the doctor's house, so it's probably similar. Domiciliary care, you know, this is vanishing, but people go attending care in people's homes. I think in low, middle-income countries that can still happen, in rural places. All that primary care. Secondary care is probably where many of us have also worked in. Hospitals, usually, bigger health facilities. Basic hospital services. And then we've got the next level up, which is tertiary care. And does Japan also have tertiary care? And in England, these are specialized hospitals offering, you know, very subspecialist treatments like cancer treatments, and we know that heart attack outcomes are better if you are doing in a specialized center. Stroke outcomes are much better if you're in a hyperacute stroke unit. So some of those are very located in very centralized expertise hospitals, cancer hospitals perhaps. So we call that tertiary care. In some ways, it's very helpful to know that, you know, often in allopathic medicine, health services are organized in these levels, and helpful to know what we're talking about when we are looking at healthcare. So these are sectors, and I've described to you a little pyramid of primary care, secondary care, and tertiary care. These are the levels of formal care. So lots more people access primary care. Lots more people. Most people, first port of call with a clinician, community pharmacy, is primary care. You go there and you say, oh yeah, I need to deal with something with my blood pressure or my diabetes. So that's the first point of contact with a formal clinician. Second, so you can see that actually fewer people are in the top of the pyramid. That's how it works. However, we have this huge chunk below, which is lay care. And lay care is not talked about much, but fundamentally important, as we will come to see. What is lay care? So I'm going to read this a little bit out to you. It's a quote from old England. Think about Charles Dickens kind of time. I was 12 years of age. The operation was done on the kitchen table. Nurse came, then the doctor. I had so much of a rib taken, cut down here and down my back. The nurse came to tend to the wound for several weeks. They gave me an anesthetic. The elder ones came in for the meal. The doctor said, Mrs. T, this is an ideal for a job. You couldn't have a better table. Everything had to be cleaned. And I remember the nurse saying, you've got everything just right. You've even got the bucket for the blood, to my mother. Is this lay care or formal care? That was quite graphic, wasn't it? But that was 100 years ago in England, and obviously this young girl had so much of an operation taken, they took something out of her, and her mother prepared everything, you know. But there was a nurse, and there was a doctor, and there was so much of an operating theatre, you know, kitchen table that was. Everything had to be cleaned, and they even had, then there was a nurse that had a bucket for the wound. So the boundary is not clear, but we know that a lot of lay care takes place, and even till today. Lay care takes place, the differences are at home. Formal care usually takes place in a formal setting, in a health center, health facility. Lay care, informal training, usually a family member. In this case, it was the girl's mother. She orchestrated a lot of her healthcare, didn't she? Then there is a formal training, which is given, how many years of medical school? Many of us? 5 years? 6 years? 7 years? 7 years, there we go. Nursing also a degree. Pharmacy, master's degree. Yeah, so long training for a lot of the formal carers. And paid, hopefully, some of us. Lay care, unpaid. Okay, so these are quite important distinctions, but the boundary is not necessarily clear-cut. Remember that pyramid I showed you earlier? There was a whole section that was lay care. The majority of the care are provided by lay people. And we can imagine if all that lay care converted to formal care, we would think that all the problems we're trying to work out about health services giving resources, the best way of funding models, everything, there'll be a piece of cake compared, So much, if all of those of the health that is provided by lay people, that shifted, that would totally shift the dynamics and the impacts it has on the resources needed for formal care. But how people seek formal care is fundamental to the lay care that's been provided. Before they even come to the general practitioner or the pharmacist in the community, they probably already asked the mom, the dad, the spouse, wife, friends, probably. It also, if their family member said, oh, no, I think you better just check that with a doctor. I don't think you're doing it right. I don't think we can cope. Let's go see a doctor. That has the implications on how people seek health care. It's part of illness behavior, which we'll talk about more on Friday. But it's important to know that as we are looking at health services, we are only looking at the pyramid that's above. And there's so much of lay care that we don't know about. Very few studies, and often, obviously, no routine records. We have no medical notes on that part of care. So, this is from, check the source. In England, they have tried, from one of the policy think tanks, have tried to quantify how much this informal care, lay care costs. And there's a lot, basically. The figures are up there. This was in 2015. Lay care mainly takes 3 forms. And as a patient or a friend, you've all given lay care when you're not being your professional doctor or a pharmacist. Mainly providing information and advice. We've all given our relatives, some friends, some advice on the health, aspect of the health. Emotional support, this is really crucial. And it can be the form of a listening ear just for a friend, or it could be just supporting them through someone's broken their leg and you've given them some company. That's really important as well. But practical assistance, that's a major aspect, and that a lot of lay care is giving practical assistance. Mostly social care, helping people with activities of daily living, elderly relatives, washing, etc. But increasingly so in taking part in giving formal medicines, home dialysis, for example. So much of it is given by family, relatives. If you can't have home dialysis, if you don't have a family to help you with it or a friend, you'll be in hospital having dialysis, right? So it's really key. A couple of studies that show patients' relatives, what kind of care they've been giving. For heart failure patients, their relatives have been monitoring the symptoms, giving medications, dressing, bathing, health seeking. If they weren't there, it would be different health professionals doing that. Similarly, renal dialysis we mentioned. So lots of practical assistance there. Okay, so who are the carers? Who are these people? Some studies have shown that for patients with motor neuron disease, 68.5% of the carers are female. I mean, it reflects who the disease groups are, but they're not young, mean age 63.2 years old. How many weeks spent caring? Look at that. It's quite a lot, isn't it? Imagine all these people were not available, giving this many hours of care, and that all converted into formal care. How how much more resources is needed. 70 hours plus. It's remarkable. These people are undocumented, right? Okay. Interesting finding. So I said they were mostly female in the previous study. This is a study done looking at couples now. And both couples are employed. And this is a study with medical couples, so both spouses are doctors, have good jobs, basically are in employment. And when they said, when your child's sick, who stays at home? These are the answers. So if they were fathers, when the 40% said they stayed at home, 41% they said, 50-50 kind of thing, depends. But if they were a mother, they said, I stayed at home most of the time, not my spouse. And the rest of it is, it depends. Interesting, isn't it? Oh no, well, my father's the breadwinner. No, these are all medical couples. So both have equally important jobs, you can argue. And also, interestingly, and they asked doctors of the views, 80% view that was the wife's responsibility for caring for sick children. So these are some insights into who the carers are. Another study in Switzerland, young lay carers. So we've got children who are also in the position of looking after elderly and others who are ill, supporting someone. This is why we're talking about this. It's crucial because capacity of lay care in high middle income countries are just decreasing. More women in the labor market. I'm sure every country is facing that. Also, family obligations are weakening and most people now live in nuclear families. City living, not rural living, no longer in big extended families, 4 or 5 generations together. Greater geographical mobility. So it all means that the elderly and the super elderly are living more alone in larger numbers. And so the capacity to provide lay care to one another is rapidly diminishing. And this has huge implications. And I think also we think about social care and healthcare as separate, but actually a lot of that it has an impact on formal care and the way people seek healthcare. Okay, all right. Formal care's attitudes to healthcare, lay care. Really, there are really 3 mainstream thoughts about it. A lot of people think formal care should expand and take over lay care. This is one extreme of the thought is that the vibrant lay care, they don't know what they're doing, it's not recorded. If they become too big, there's less resources for formal care. It's very out there. Some things formal care should train and control lay care. Oh no, we must give them a system, teach them how to do it, train them, and then have them under our control, and then they can be granted and give care. Yes, you can give that drug there. Yeah, that's the way you do it. Kind of so much more control. And really, in the other end is formal care should encourage a vibrant and support lay cares. They should be allowed to flourish and support to help because we actually cannot meet all those needs. And it's important to have an alliance. It should be supported, it should be encouraged, and independence encouraged. So there are different perspectives on how we should deal with this. Okay, so that's about lay care, formal care. It's good to have a perspective of what's underneath that pyramid that we can't see. Disease and patients. This is fundamental to our inputs and understanding of health services. And as many of us are clinically trained, we go through our university thinking, this is a drug, this is a disease. This is how we diagnose patients, this is how we treat them. But very rarely do we consider disease as a social concept, that actually these are not fixed. It is fundamental to how we define and study health services because how we define healthcare and what we do is so much driven by what is fundamentally what the patients are, what the disease are. I think it comes down to 2 crucial questions. What is disease? What are diseases? First of all, what is disease? There are 2 approaches to define disease. Firstly, it's a self-assessment. It's a felt need, a need for health. Oh, I have a really bad headache today. That is my self-assessment. It's inherently subjective. You don't know how bad my headache is. It's really bad. It is just really bad, my headache today. So you as a doctor can't tell me how bad my headache is. It is very a personal experience. And I don't know what your headache is like. Also, people, what they do and what they expect from headaches vary. The Stoics think, I'll just sleep it off. It's a headache, I can sleep it off. I don't trust pain medications, no way, sleep it off. The hypochondriacs, on the other hand, is like, oh my goodness, it might be a brain tumor, I better go see my doctor now. And then so, it is very variable. And this is all a subjective assessment. It's not concrete in any way. Then we have a different perspective of disease, the biomedical perspective, which we are all very familiar with in our professional capacities. We call this sometimes the need for healthcare, a normative need. And it's normed because the doctor or the professional says you have a disease. It's objective. It's often based on combination of signs and symptoms and measures, probability, blood tests, statistics. And we say, oh, it's likely that you have this syndrome or this disease because you have these symptoms. You've got pain and you're right. Iliac fossa, umbilical pain, and you're nauseous and vomiting. Oh, you've not got an appetite. Very tender. Maybe you have an appendicitis. That kind of diagnosis is a biomedical, normative, objective, and decided, crucially, by a healthcare professional. So what is disease and what is not? We go through our training thinking, disease is one thing. Well, actually, would we say traditional foot binding in ancient China is a disease? If you look at the x-rays of women who had the foot bound, you'll be like, oh, disease, so many fractures. But actually, all women had that. There was beauty. Not disease, not seen as disease in the society. Why is your foot not bound? It must be bound. So, back then it was not disease. Now we look at it. Well, every orthopedic surgeon might gasp and go, oh gosh, painful, something like that. Malaria, many countries, in UK, if you've got parasitemia, you have malaria. In endemic countries, most people have asymptomatic. They're not considered diseased. Mental health, really interesting. So the studies suggest that 165 million Europeans a year suffer some form of mental disorder, mental condition. 38%, that's a lot. What does it mean? Where's the boundary? How do we define? If you were sad sometime in your year for a period of time, are you depressed or are you just sad? Are we as a society saying that we shouldn't be sad, we should all feel great, feel normal? If you have a period of time where you're sad, you have a mental disorder. Not saying it's not important, but it's interesting how we perceive it. In society, a fourth leading contributor to the global burden of diseases, indeed important. But it's how we, as a society, come to define disease is interesting, isn't it? Interesting articles here, controversial. But, which side do we put people, in a sense, as a label, isn't it? How do we label people? Are you just slightly odd and eccentric? You're just slightly odd and different? Or if you've got a mental disorder, is a personality disorder? It is very up for debate. So some interesting conversations there that talks about, how we define disease. This is a very interesting study. It's from some time ago in the 90s in England, looking at the reasons for retirement of different public body service sectors, the public sector workers. Armed services, only 6% retired from ill health. Fire officers, 73% retired of ill health. Is it because they're all getting really sick from their, firemen getting accidentally burnt in the work? No. And then whereas armed services, everyone's really well. It's actually because for their financial protection and retirement protection. So as an fire officer, you retire with ill health. you're protected, you're remunerated for your contributions financially. Whereas actually, if you were in the army, you were protected anyway, so you don't have to retire with ill health to have those contributions given to you, your entitlements, etc. So it's very interesting, isn't it? How people define disease is not fixed. There's also geographical variation. Some areas in England, police officers were more sick, 60%, more than 60%, and then some officers were 20% less. How interesting. A local government as well. Really? Local government, and police officers being 2 to 3 times sicker in some areas? It's very odd within one country. So when they quit their job, it's how they record the reasons. So for the fire officers, because they were going to be protected financially, if you left your work with an ill health, so they record themselves as recorded as being sick, whereas others are not recorded. It's just to highlight the discrepancies of recording, but also how we define disease. Is it a bit of stress? Oh, I'm very stressed. I must go down in my medical notes as stress.
So
Yeah.
I'm very surprised because in Japan,
Yes.
the public servants never quit their job. It's a very good job in our society.
Yeah, because if they quit, they don't get paid with a remuneration. I mean, this is not necessarily quit. I think it's retirement. So, yeah, I mean, there is a bigger question as to why are fire officers retiring. Are they retiring prematurely? This is not clear, but they're retiring with a reason for ill health and not. So many different reasons. There might be many, legitimate reasons underneath. I'm not saying this all spurious, but it is interesting that if we consider it in perspective of how come these people are so sick. There are many implications for disease classification. Just to put down there are employment rights. If you've got such a good job, you don't want to quit. Japan public servants, it sounds like very fit and well till the end. Insurance companies, compensation. Oh, whiplash pays out so much, doesn't it? So many cases of whiplash, documented in the States when the insurance companies changed their policies. Lots of other reasons. So, what are diseases? It's a pattern of factors that occur in many people in more or less the same way. As doctors and pharmacists, we would know that very easily. But how do disease categories arise? There are really 4 reasons. Real changes in occurrence, changes in name, changes from a single to diverse categories, and the changes of recognition of abnormal. We covered some of the last point already. But some examples of what these might be. Real changes in occurrence, HIV/AIDS. Jia Sensei works in that field. Before the 1980s, no one's heard of that before. It didn't exist. It's a real disease that emerged. SARS, similarly, in our lifetime, that was a new disease, or new that we've recognized it. Changes in name, coronary heart disease, what it used to be called, unstable angina, changed many years of name. Before that, it was something else. Subdivision of diseases, diabetes mellitus, diabetes insipidus, type 1 diabetes, type 2 diabetes, more and more different categories, and there's probably more and more you can list your name. So we also have changes in the recognition of abnormal. Not very long ago, Germany was still treating for low blood pressure. So it was below 90, it was unhealthy. It was systolic, so they would raise it. It was interesting, isn't it? I don't know if Japan treats low blood pressure. But we're also uncovering previously rare conditions as well. So we also talked about the importance of diseases classification for socioeconomic implications. Okay, so moving on. Whirlwind tour. Understanding professions. Very crucial inputs of health care. Who's the most powerful professional in the health service? It's not a trick question. Yeah. The concept of a profession is interesting, isn't it? Weber had a really nice criteria, definition, description of a profession. Characteristics. He said they have a body of specialized knowledge. If you think about the doctor or the pharmacist, yes, they're very knowledgeable. They're respected for their knowledge. How many years of training? 7, was it? To even qualify, and that's not even specializing. To be able to sign that prescription notes or say doctor or something, or give you advice on your medicines. It's so long a training. Monopoly over practice. In England, we have a general medical council. You have to be registered to practice as a doctor. Similarly, there are registers for nurses and pharmacists. Not anybody can be a nurse. Can't be like, oh, I'm a nurse, I'm going to come and work in your hospital. No, you have to be certified, you have to be registered. Is that the same in Japan? Yeah. Code of ethics. A lot of doctors, before they start practicing, they take an oath. Is there something like this in Japan as well? And a degree of altruism. So this is what Weber said is a profession. And it's really helpful for us to understand that level of degree of power, degree of autonomy from a profession. We know because, in the medical profession has come to dominate the healthcare service for reasons that we talked about already, different historical influences and also professional expertise. There they derive professional power, technical expertise, authority and autonomy. The third one's really interesting, clientele. It is that particular relationship that's really special. And that's not unique to doctors, pharmacists have it as well. And that unique engagement and personal relationship based on trust between the patient that comes and seeks your advice and that professional that gives that patient a professional advice. Crucially, uncertainty. Health is an agency relationship. We would come to discuss that. There is uncertainty over what I need and what the outcome is. And so I actually want to seek advice and the advice of experts. And actually it's getting rare in modern day for us to want to seek advice. There's a rhetoric in a bigger society about, done with the experts. We don't want to hear about experts anymore. We've got social media, we've got news updates, news feeds. But actually, health is still quite unique in that we actually do care about the advice of the experts, for my health at least, for your health. When you're a patient, you want to be in that position to seek advice. And so it's very interesting to understand the power and how power comes from deriving. And you will come to see that power is quite core as to a lot of why the health services are the way they are, from the influences that we briefly covered this morning. We talked about regulation and peer review, and some of these processes propagates the power of the profession. For example, subjugation. Usually there's a hierarchy within medical structures. In England, at least, medicine's very hierarchical. In the past, I think this is slowly changing. In the past, there's also, doctors are seen as, you can tell the nurse what to do, more or less now, but there's subjugation of other professions. Limitation, so, you can't practice unless you're registered. As a medical doctor, we can't practice dentistry. I can't look into people's mouths and go, I'm going to take your teeth out. There is limitation on what we can do. Exclusion as well. We say what is medicine and what is not. Allopathic medicine is medicine, but osteopathy, homeopathy, that's not medicine. Acupuncture, let's call it complementary medicine. So there's a strict criteria and exclusion of things. So that propagates this power of professions. Slightly moving on to a quick topic, just so that we're aware that healthcare is a large employer of staff, but also a huge employer force of mobilization internationally. And there are, the workforce is important. And there is a high income, low income shift and push-pull factors. And inequalities do come from the global health care workforce as a result of migration of these resources. It's a nice little diagram talking about migration of health workers, just to be mindful that the inputs that make up the health services are crucial. Finally, just to finish off, the users of healthcare. Who are these? The patients. Very crucial. There are different models, and we briefly touched on it already, of healthcare delivery. But it comes to see the dynamics between the interaction we talked about between the doctor and the patient, and how of the relative power of those patients. And tomorrow in our seminar, we're going to do a little bit more deep dive in looking at that agency relationship and looking at that relative power interaction. But first of all, we have the traditional model of users as patients. And this is where the doctor says it. Tells me to take a tablet, I take a tablet. I am here to seek the advice of the healthcare profession. And I am a patient, and I have my sick role, and I defer the decisions to the doctor. And the doctors have full autonomy, and they advise and give treatment. So this is where the patient, the user is seen as a patient. Then, changingly, increasingly, we are seeing users as a consumer, and certain more so in market models of healthcare, where patients are the consumers, and they have choice as to where I am actively informed purchasing this healthcare. I think this surgeon's better for my knee replacement. I am going to go to this hospital because the outcomes are better. I want surgeon X, he sounds good, he's famous. I'm going to go to surgeon X for my treatment. These are as informed as possible, but these are consumers making an active choice. I want this Apple TV, and I want that phone, right? I don't want this phone. These are consumers. It's a similar kind of model, and increasingly there are aspects of healthcare which we're seeing this choice in consumers. So these are users who make informed choice. In some countries in Europe where they have social insurance, public can choose the packages of healthcare they want, and they compare the prices of the different insurance, and they make a choice. They say, oh, this is cheaper, I'm going to go for them. So that is the choice. And then there's the third, which is increasingly in the conversation, where users are citizens. What does that mean? Well, in a kind of more broader sense, we know that there are lots of health promotion activities where actually citizens have to be consulted. There's the activities of healthcare that actually citizens lobby and well, I really like my hospital. No way you're shutting that down. I know our A&E is small, but we like it. We like it in our doorstep. We're going to have it. So these are very informed lobbying. Members of the public, patients who actually are participating in healthcare issues, are well informed, are discussing in a dialogue. They're defined, and they have sharing collective experiences. It could be a disease community, a diabetic community. They may want to shape diabetic care in a certain way. They could become very influential, and the governments listen to them, and they have meetings. So these are users as citizens. We talked about a lot of this already. Shaping healthcare delivery, community model. Yes, so that's the name of the models given to the different roles of users. And that is my last slide. Thank you very much.